We're very excited to share with you our piece in all this work. So thank you so much for the warm welcome and for having us. My name is Kristen Klopp. I brought my coworker along with me today, Deb Heisey. We are community case managers. We work in post-acute care at Lancaster General Health. It's a hospital in Pennsylvania. We're going to talk to you today about how we enhanced person-centered advanced care planning conversations between our health system and skilled nursing facilities in our community. Let's see if I can get this clicker going. Okay, so as I had said, we're from Lancaster General Health. LG Health partnered with Penn Medicine Health System a few years ago. Just some background information about Penn Medicine. They've been consistently ranked among the nation's best overall hospital and in multiple specialties by U.S. News and World Report. Penn Medicine, by the numbers, they have over 2,500 licensed beds, over 5,000 licensed physicians. They've been awarded over $700 million in research and education. They have an operating revenue over $6.7 billion, and they have over 35,000 employees. Lancaster General Health has about 800 beds within the Penn Medicine system. As you can see by the map there, we're pretty spread out across Lancaster County. We're made up of 34 primary care locations, 19 outpatient locations, 31 specialty and surgical practices as well, and we have 6 urgent care locations. And just a little more, for the 2018-2019 year, U.S. News Best awarded Lancaster General Health 6th best hospital in Pennsylvania. We have marks in high performing for procedures and many procedures and conditions, and we also have high performing specialties, 4 of them: gastroenterology and GI surgery, geriatrics, orthopedics, and pulmonology. We have been rated as a top teaching hospital with high safety scores. We are Joint Commission certified, and we have been accredited for a 4th time in 2016 for Magnet recognition, which is one of the highest honors for nursing excellence.
So we have some learning outcomes that we'd like you to meet over the next couple of minutes. We'd hope that you were able to discuss the impact of an advanced care planning collaborative between our healthcare system and what we call our preferred provider network. This is a network of 9 continuing care retirement communities in Lancaster County. And we selected these facilities as preferred provider facilities due to their high quality outcomes, their star ratings by the Centers for Medicare and Medicaid, and reputation for positive clinical outcomes. So our health system partnership with these facilities promotes improved care through the use of improved communication, medical care, standardized clinical pathways, and now advanced care planning initiatives to meet the goals of the quadruple aim. We also hope that you're able to describe at least 3 implementation strategies to provide education, engagement, and workflow redesign for advanced care planning among stakeholders in continuing care retirement facilities in your own communities or in your particular areas of service. Lastly, we'd like to share the outcomes that we were able to achieve in hopes that you will be excited about collaborating with retirement communities in your own areas and to enhance person-centered advanced care planning conversations. So many people and their families never take the opportunity to talk about their wishes in advanced care planning. We know those missed opportunities have devastating results in many cases, particularly among people who suffer from chronic comorbid conditions, who rotate in and out of the hospital and in and out of skilled nursing facilities multiple cycles before end of life. We know that patients and families can be robbed of the best quality of life possible in these final stages without clear goals for advanced care planning. In this population, we found many missed opportunities to support person-centered conversations with the patient and family across the continuum of care. The hospital always pointed to the skilled facility to hold the conversation, as health professionals in acute care say that they have such a limited amount of time with the patient in an environment of shortened length of stay. Whereas the skilled nursing facility staff pointed to the hospital to have the conversation because skilled nursing facilities think that hospital staff is where we have the patient's and family attention during acute illness, and surely we can hold these conversations during that time. So a lot of finger pointing. I know that all of you have experienced that in your healthcare systems. So once we leveraged the electronic medical record to support advanced care conversations across the continuum, we went to work on collaboration with this preferred provider network. We wanted to capture more opportunities to work together to enhance person-centered advanced care planning conversations that may, in some cases, prevent those unwanted readmissions and, more importantly, allow individuals to experience the planning of their goals and wishes during advanced care planning conversations in the manner that they felt most comfortable and reflected their wishes. Several years ago, leaders at Penn Medicine and LG Health were able to develop a system-wide strategy for advanced care planning. Stakeholders were convened to spread the Gunderson model and pulsed implementation throughout our community. We felt very strong foundational support to move forward in our work with the Penn Medicine Lancaster General Health Preferred Provider Network. In this work, we convene monthly to discuss 30-day readmission cases, and themes are found, and it really didn't take long to discover that missed opportunities for advanced care planning arose as a number one most common theme and ripe for our work. And from this monthly committee meeting, we comprised what we call an advanced care planning workforce task force. The task force developed an advanced care planning toolkit that Kristen will tell you about in just a minute. Other strategies for the task force included respecting choice staff education at each facility and the development of a consultative model to redesign and or strengthen advanced care planning workflows into existing initiatives in the 9 preferred provider network of skilled facilities.
Okay, so before I get into the actual toolkit and what we developed, I want to take a step back to talk to you a little bit about the why. I think it's important to explain what brought us to this work. So as Deb mentioned, our Advanced Care Plan Task Force was convened in order to actively work on addressing ACP themes that we discovered as a result of many of our unplanned 30-day hospital readmissions. The first task force meeting was really interesting. It was definitely eye-opening. We did sort of a round-robin discussion with our facilities where we discussed what brought each of them to the table to pursue this work. We heard lots of impactful stories and cases that really could have had better outcomes. So we felt it was a really great exercise to kick off our task force. We ultimately found that our facilities were struggling with supporting patients and families in honoring end-of-life wishes, as they didn't really have the tools available to do so. So the facilities had expressed difficulties in having late-night crucial conversations with providers and families around actually enacting goals of care. So I'm going to expand on that just a little bit. I'm sure many, if not all of you, can relate that oftentimes we find that patients and families who've chosen comfort care as goals end up panicking and requesting transfer back to the hospital when push comes to shove or when it's time to enact that DNR pulsed. Seeing a loved one go into respiratory distress at 2 a.m. or having patients with increased amounts of pain, it's very uncomfortable. So why do patients and families end up back in the hospital or in the ICU bed on a ventilator when their wishes clearly state DNR, do not rehospitalize? Because they're scared. From the patient's and the family's perspective, I think we can all empathize that it's one thing to elect comfort care, and it's a completely different thing to actually experience those common end-of-life symptoms like shortness of breath, pain, and confusion. So we learned very quickly that we would have to work together with our partnered facilities to create useful tools for both patients, families, and providers in honoring end-of-life wishes in this skilled setting. So in sum, the tools that comprise our toolkit, our advanced care plan toolkit, are the following. We created a generalized comfort care-based patient and family clinical pathway. We standardized communication, scripting, and person-centered tools and framing around comfort care discussions with providers. And we identified and are supportive of subject matter experts. We're calling them advanced care plan champions in the facilities. And our toolkit is also comprised of some standardized education programs for patients and families around end of life. So I'm going to discuss some of the tools in a little bit more detail in the next few slides. So this slide shows what our comfort care pathway looks like. Patients and families keep this at the bedside when choosing comfort as goals of care. The pathway is broken down, as you can see, into specific categories or buckets with information to help patients and families in what to expect from their chosen goals of care. As mentioned before, and as I'm sure you all know very well, patients will often elect comfort care without really understanding what the journey really looks like. This pathway helps to give them some context for that care. We listed out some common symptoms there in the bottom middle that patients experience in comfort care or at end of life. And then we go on to say that patients and families can expect to develop a plan of care with the staff to help relieve some of the symptoms that are seen in end of life. So we have found that this pathway has been largely successful with our facilities, and it's been helpful in helping the facilities manage patients in the post-acute setting, and honoring patient and family wishes according to our facilities. They've actually said that these pathways have helped to increase their patient satisfaction scores, so we've seen a lot of positive result with this. Some of you may be familiar with the term SBAR. For those of you that aren't, SBAR is shown by this slide here. It is a format used by clinicians when contacting providers with acute needs. We developed scripting using the SBAR format for our facilities to use when calling providers, in particular around their wishes and how to honor those goals of care in hopes of avoiding unnecessary ER visits and hospitalizations. With this format, clinicians are guided and encouraged to engage in conversations with providers, keeping goals of care and end-of-life wishes on the forefront of the conversation. Unfortunately, we found a lot of times that these types of conversations where someone's advanced directives were being enacted or needed to happen really on off shifts, where providers may just be on call and they don't know the patient's individual case. So this scripting helps with that. Without a solid background and understanding of the patient's medical problem tied into whatever their wishes are for end-of-life care, many of those cases ended up coming back into the emergency room or the hospital despite outlined goals of care. So the scripting we created with our partnered facilities in this SBAR format is person-centered, and it keeps the goals of care on the forefront of the call. In turn, we've been able to honor more patient and family wishes and unnecessary hospitalizations. We have also, as a side, formatted some scripting for providers to use with patients and families if they feel they need the support and guidance, as well as scripting for clinicians when addressing patients and families in these critical situations. Our goal in working with these facilities was to have each facility name 1 to 2 people within the organization to become or take responsibility of advanced care planning, becoming a subject matter expert or a champion. This slide shows a flyer that we made to advertise for this role at each of our facilities. So this champion could be a chaplain, a social worker, a nurse, an administrator, or some type of leadership, or even a provider. And by responsibility, we mean not that this person should actually be taking on all of the advanced care planning discussions needing to happen in the facilities, rather becoming the designated change agent for ACP within the organization. So some examples of what we were empowering this ACP champion to do is understand the workflow design of each facility in regards to how these conversations are going. Are they happening? Are they not happening? Making recommendations to and with leadership to improve workflow in the organization around these conversations. Working with leadership to ensure staff has formal ACP training. Being a leader or a support guide to other coworkers in working through difficult and complex ACP conversations. Our overall goal with this champion role was ideally to have a staff champion and a physician champion at each of the facilities. We are proud to say that we're still working on that. This task force is not convened. We are continuing to work with our facilities, and this is one of the big things at the table here.
So we've been doing this work since November of last year, so it'll be almost a year. And during that time, we trained 58 staff members in 6 of the 9 PPN facilities in respecting choices. We have 9 advanced care planning subject matter experts across those 9 PPN facilities, and then of course we have the toolkit that we developed. So the large facility number 3 there, was very much of a collaborator with us because they owned their own hospice. They taught us an awful lot about things that we needed to share among the 9 facilities, and so the power of collaboration and picking your partners there was really behind us. And so our trainings are ongoing. Right now we're on a little bit of a hiatus because we're looking for a formal advanced care planning facilitator. So if any of you would like to move to Lancaster County, Pennsylvania, you can see me afterwards. We need some good talent. So you can see our readmission rate here is on a downward trend, and really there are of course many variables that contribute to the success. Anecdotally, we feel that the interventions that we completed in the Advanced Care Planning Task Force paid some contribution. Here we, in November, we convened the task force and we trained skilled nursing facility staff in January. During January, February worked on the scripting, March worked on we were working fast, worked on the comfort care pathway, and then deployed the remainder of the toolkit around April. So we continue to come on a downward spiral with our readmission rate, which this work is more than just decreasing the readmission rate. It's really about honoring patient and family goals and values and supporting those goals and values across the continuum of care through interprofessional collaboration that we heard a lot about earlier in the week. We're very happy to answer any questions you might have at this time around the learning outcomes or any of our implementation strategies in collaboration with our health system and our area retirement communities. Thank you so much for the opportunity to be here. Yes?
So these are all SNF patients, not ICF patients?
Correct, yes. Mm-hmm. They're all SNF patients. Mm-hmm. Mm-hmm.
So my question was, are these all SNF patients as opposed to ICF patients, which would then preclude them from choosing a comfort-focused treatment pathway and be moved to hospice? Because they still have to get therapy, or else they get kicked out of the SNF.
They do, but we worked in that entire population, in that entire SNF population. Irregardless of what their choices were, we worked with them to get the conversation completed and completing the documents in the end. So, and to work towards whatever their wishes were. If that was hospice, then we worked to get them there.
Some cases do end up going off to hospice, even inpatient hospice. But you know, the Lancaster County is made up of a lot of continuing community retirement communities, and they want to stay in that system. They get to know the caregivers. You know, they're from independent living. They cycle through the hospital. They cycle through skilled for some short-term rehab. They head back home. Some of these people, you know, they're in the retirement community for many, many, many years. And by the time they get to skilled care, they want to stay in skilled care. So this is part of that, you know, comfort care-based approach. So this would actually be, for a lot of these patients, they're not actually choosing hospice. They're staying with the skilled facility staff, if that makes sense.
Well, I'm just concerned from in my experience, and I don't mean to be grumbly. In my experience, the problem comes from, you know, no one wanting to give anybody the appropriate comfort-focused drugs and have them still stay there and not be on hospice.
Therein lies the challenge. Therein lies the
okay,
challenge.
all right.
Yeah.
I just hoping you had a magic answer.
Oh yeah, I'm sorry. I'm sorry, but you know, the more conversations that you can have, and more that you can help people understand what their true goals and values are, the easier you can get them to move to that next level, where we're not sending an end stage cardiomyopathy, heart failure, 6 times admission in 6-month patient for skilled rehab on a Med-A benefit, when really, you know, you're hoping that the patient, you can get that patient and family to accept hospice or comfort care measures, so, which is a challenge. Yes.
I apologize in advance if you did say this and I missed it. I was texting a colleague about one of our patients. I'm from Southern Indiana, working with palliative care, and I was curious how relationships with palliative care, especially for those patients, because we see that every day. We know they're hospice appropriate. Patients and family want hospice, but they don't have the financial means. And so when that's identified, does that trigger referrals to palliative care, or how's that relationship?
We have a very strong relationship with palliative care in our heart failure population. We have them centralized in our acute care hospital downtown, but we don't have the bridge into the skilled facilities is just not there. It's not there once they once they discharge and they opt for short-term rehab.
So does palliative care not go into the facilities?
They do not.
Oh, see, we are blessed that we go into these skilled nursing facilities, so we can write the the narcotics. However, we're not there after hours. We're 8 to 4:30.
We do have we do have all of our geriatricians that are employed by our health system.
Okay.
Each one of them is the medical director in all of our 9 preferred provider network facilities. So they are really good about palliative care and comfort care, and
then
we're thankful for that.
One other question: that script that you talked about, is that something that you share?
We could, yes.
Okay.
We could. It's you know, Kristen, I'm sure she did a really good job about it, about the script, because when we sat down with the task force, one of the #1 things they talked about, Kristen said, they were so frustrated as staff in skilled care about how can they really explain to this provider on the phone in the middle of the night, who's not around the building all day, who hasn't known that patient and family, like, how can we tell them this is not about treating the fever of 100.8 and sending to the hospital. This is more about, here's what matters first. Here's what matters first. I want to tell you this first. And I want you to trust me that I know this patient and family, and then I want you to make your decision based on that. And that's so hard to get across. We are actually building that into staff. We're not doing it. Our skilled nursing facilities are building that into their staff competencies, to how to speak to providers around advanced care planning.
So there's a corollary to this, which is, how do you call the family and tell them that their loved one is declined and may die, and then say, you know, I mean, this was something we identified early in La Crosse, because we had all these people who didn't want to come back to the hospital, coming back to the hospital. And it was triggered by either the phone call to the physician or the phone call to the daughter. And as best I can tell, you know, it's 3 o'clock in the morning, you call the daughter and say, your mom's really sick, she's got a fever, what do you want me to do? And if you ask the question that way,
That's exactly
the
right.
answer
Yeah.
is almost inevitably send her to the hospital.
right.
So we had to help the nursing homes develop scripts that said, your mom's developed a fever and she's declining. I'm calling you because I think you might want to come in and be with her. You know, we have this plan in place that represents her preferences, that she just wants us to keep us comfortable. So to be
just
bold
like ours.
enough to actually explain what the plan is based on the patient's known preferences to the family, so you're not putting them at 3 o'clock in the morning out of a dead sleep, thinking they have to make a new decision on the spot, which almost inevitably is to treat the condition, which may be not a good thing.
We'd also like to hardwire some of that. We talked a little bit about identification points of how to identify that preemptively, like maybe a week before, some interval before, that says your PO intake's been down, you've had more lethargy, you can't make it to your loved one can't make it to the dining room, they haven't been as conversive. So we just want to talk to you about what is going on. Here are some interventions we're doing. We would not be surprised within the next X amount of time. So that's part of an advanced kind of conversation that we're working on. Nice. But we have our county is like a mecca of retirement communities. It's like what Lancaster County is one of the best places to retire. It's actually on some important list. And it's because there's so many different retirement communities, and we have one that is particularly lucrative. And it looks like you're staying at a 5-star resort, any place you go in that facility. And they are the loudest proponents of people that live far away, because their loved ones come there from all over the United States. Yep. And so they haven't seen their loved ones, mom, dad, grandma, grandpa, for months. And all of a sudden they're getting this call. So it's really a challenge for that retirement community to work with that population and try to communicate with their families earlier on to try to intervene. Yes? Mm.
So I've always said that the hardest job in the entire healthcare system is being the LVN on a Saturday night in a retirement community.
Yeah.
Because usually he or she is there mostly by themselves and with everybody else saying, oh, we won't have to call, I don't have to call, it'll happen tomorrow and I'm off tomorrow, and that sort of thing. And the scripting of that is just so important, and really, trying to get the director of nurses and the medical director of a facility to really, really identify that person and pat them on the back every once in a while.
Yes, thank you.
We're very, very lucky that we work with geriatricians that are partnered, that work for our Lancaster General Health System in these 9 facilities. That gives us huge leverage because they're wonderful geriatricians, and the one that comes from the facility number 3 with the hospice, I love the way, he's the only geriatrician that sat on this task force. He's just a wonderful, wonderful provider. And he says, he doesn't usually like to interrupt nursing's great bedside manner. But when nurses, when they call him in the middle of the night, his first question is, do they have a pulse? What is the advanced plan? What is the advanced directive? What is the plan here? And before he hears anything clinical, and it's helping. We need to have that in more of our providers because it really starts there. I mean, it's certainly a collaborative effort in that on-call time, but the provider, is really key, to kind of bring that forward as well. So.
Any other questions? We have one more question. Thank you.
I'll just comment as Kate's coming up. The teams that we've worked with worldwide that have been successful in the kind of long-term care space have been able to incorporate good advanced care planning, these kind of scripts and communication tied to an increased capacity of the home or facility to provide palliative care and to access palliative services. Because if people say, I want to stay here, but I want to be comfortable, and you can't provide the comfort that they really deserve in that facility, you're going to ship them. So it's the combination of being able to provide the palliative services that meet the preferences of the patient that'll really allow you to honor the patient's preferences.
There's a lot more work to do, but it's been very rewarding.
Yeah, thank you.
Great.